Okay, well, thank you very much for the opportunity to speak today. But first of all, I'd like to acknowledge that one of my colleagues, Raylene, who is unfortunately unable to be here today, has put a significant amount of effort into this presentation. She may be viewing online. Hi, Rails, if you are. However, I do appreciate all her work. Thank you. So first of all, I too would like to acknowledge that we are meeting on the Dja Dja Wurrung, Yorta Yorta and Barappa Barappa, Wemba Wemba, Lachi Lachi and Turarong country, and pay my respects to the people who are the traditional custodians of the land we meet upon today. I'd also like to pay my respects to the elders past, present and emerging. Just for those who are not aware, today we're probably really drilling this down to a bit more of a local perspective here in Bendigo. And I think it's just absolutely fantastic the way this forum has evolved, that we've actually been able to look at global issues, to look at the data, to look at some fantastic research. And as a nurse working in Bendigo for the last 20 years, it's just really now really wonderful to be able to really look at the coalface of viral hepatitis in our community. And today our presentation will be focusing, as I said, on pregnant women with chronic hepatitis B in our refugee population. But the infectious diseases team at Bendigo Health consists of all these people. I want Jane to give you a wave today, Jane Walker. She's one of our nurse consultants in the VICSIS, and that's to do with people who have difficulties with the COVID vaccine and need specialist involvement. So basically today our topics will be really concentrating on pregnancy and postnatal care of the refugee community in Bendigo. And now I'd like to introduce our guest speaker. So, Tahe Brown is a bilingual project worker in the Health Navigator program at Bendigo Community Health Services. She was born in Myanmar, arriving in Australia as a refugee in 2010. Has previous work in healthcare and childcare, and is currently studying her applied social science, majoring in counselling at La Trobe. Yep. We're going to talk a little bit of a brief overview of hepatitis, and just really in relation to the main purpose of our presentation is around the case study, and hopefully there'll be some good questions in the end. So I'm just actually going to hand over to Tahe now to just introduce herself, and she's been very welcoming in being able to provide her story.
Thank you, Louise. Hello, everyone. And thank you for having me here. I just want to share a little bit of story. So I was born in Myanmar, current state, and I'm a child of 9 siblings in my family. And before I was born, 3 of my siblings passed away due to unknown illness. And when I was 9 months old, my dad passed away due to an old injuries that were affected. I was really young, and obviously I didn't know much back then. But according to my mom, she said that all those illness and all the infection to my dad, it could be easily healed, and with proper medications and safe environment. So shortly after my dad passed away, the Burmese military came to our village and attacked us. So we were forced to flee our village, and many of the villagers got killed, including my uncle. And we have to flee by foot. To get, it took some weeks to get to the refugee camp on Thailand border, and this is a story to represent all the current people, refugees that settle in Bendigo, because we all lost someone due to illness or due to war. And according to the research of humanitarian, refugee camp has been present in the world for 17 years. Before many of the Korean refugees, they have been in the refugee camp for longer than that, and some were born there, some were married there, some have kids and die in the refugee camp. And current people are stateless, And many of us still in the current state hiding in the jungle for the Burmese military, and some are still live in refugee camp, and a lot of us also have moved out to the country, like USA, Canada, Australia, and Europeans as well. So I came from a refugee camp called Miramar refugee camp, and we had about 10,000 populations, people in there, and I lived in there for 11 years. I remember in the refugee camp we have 2 clinics. It's very small, but even though we have that clinics, we have very limited medical supplies, and we will have like some basic medication like pain relief, like paracetamol, and so many of people refuse to go to the clinic because it's helpless to them, and they will often use home remedy medication instead. And there were very few resources and support for people who suffer from chronic health issue like diabetic, stroke, or hepatitis, and also lack of support for people with disability as well. So because of this issue, a lot of current people, even though we came to Australia with a lot of healthcare services, there's still a lot of barriers in seeking healthcare in there as well. Yeah.
Thanks, Diane. So as you can understand, we're going to have a bit of an interactive presentation today in regards to our case study that'll hopefully illuminate some of the known barriers, but also probably be very thought-provoking in how each one of us individually can assist with our own service that we work in, and also perhaps influence other people in our lives. So I won't dwell too much in regards to the data. So as we know, there's variation in data that's been presented today, and there's variation in year to year. But what's really important for us is around the importance of the countries of prevalence, and for us in Bendigo, capturing those people at-risk populations. There's also been a significant conversation today in regards to transmission of hepatitis B. And I suppose one of the important things we have in terms of women who are with chronic hepatitis B in regards to mother-to-child transmission is that to be careful in the language that we use so as not as to blame the mother for potentially infecting their baby. And as we've heard, there's sometimes not even words in the dialects of the languages of people from refugee migrant countries to actually understand that meaning. We've heard how vulnerable women are during pregnancy, any woman that's pregnant. So it's particularly important from our perspective to be mindful of that. And that ultimately transmission is not always known, and it's very good opportunity during pregnancy or for those who are planning a pregnancy to have a conversation about the households. We do know that there's often in our refugee families a lot of people living in the house together in family groups, and it is important to understand that and have a conversation. And one of the things that is very important in terms of discussing the course of hepatitis B, particularly with women who are pregnant, is that it's quite complex, and we've heard that today. And we also need to just be mindful that hepatitis B virus is actually oncogenic. And for those who are not pregnant, but those living with chronic hepatitis B, is that we have to be mindful that this virus is a bit tricky and can actually lead to cancer with someone being reasonably unaware. We've heard today that the main predictor of the disease is actually disease course is actually the age of infection, and so we've obviously heard today that infants infected with hepatitis B rarely experience any symptoms, but 90% will develop chronic hepatitis B and lifelong infection Children often don't have symptoms, but a significant proportion of them will develop chronic lifelong infection, and adolescents and adults tend to have acute infection symptoms, but however, a small proportion of those go on to have lifelong infection. Testing, we haven't really talked about testing very much, but in the context of the testing, what's really important for us is to talk about antenatal screening that's commonly done. It is important to understand that the quality of the testing that's ordered is predictive of how that woman is actually seen in the either GP clinic or in the antenatal clinic. And what is commonly seen throughout our understanding in the infectious diseases service, that a GP who orders hepatitis serology, quite often the labs will do a hepatitis B surface antigen and a hepatitis C antibody. And so they actually miss a significant, important aspect of looking at that core antibody. And one of the important aspects of educating clinicians and other people working with pregnant women particularly is to actually ensure that the right tests are actually done. And that has been important in terms of women who've come to us and found out that they've actually only had hepatitis B during their pregnancy. Sorry? Oh, okay. Well, do you want to take a photo? Yeah. So I'm just going to ask some questions of Tahe as we move through our presentation. So Tahe, what do you think are some of the cultural barriers that Karen refugees in our community would have in regards to completing some blood tests?
So I think the main barriers for Korean, we don't necessarily have culturally barriers to seek any healthcare, but we do. I think the main barrier is the language, and also because all the medical terminology are really new to them, all the texts and technology are really new to them. So it could be really confusing to them as well. So a lot of them, and usually because they don't really understand why they need to do the test, unless they have the symptom, they don't go and seek professional help. Because they have never seen any of these when we back in CAP and experience any of these tests before, and those are the very common issues.
Put my glasses on. So what are some ways that we as healthcare workers can encourage people to complete their testing?
So I think the best way to support the current patients is, I think, because usually when they go see GP, they usually have interpreter, but not at pathology clinic or any test clinic. So they provide an interpreter in that area, and also really explaining why they need to get the test and what's the beneficial of it, and then what will happen if they don't get the test, and also explain it in a really simple term, even through interpreter, because we don't have a lot of word translated in Korean, so it could be really hard to understand even though it's translated in Korean.
Thanks. Does anyone have any other questions? Okay. So in terms of, we've heard a little bit about treatment, antiviral medications for chronic hepatitis B in pregnancy. The decision to start the treatment for adults during pregnancy is guided by the single hepatitis B viral load test. And in our case study, we'll talk a little bit about the importance of that and what are some of the issues when that's not attended. If the viral load is greater than 200,000 international units per mil, then treatment is required to reduce the risk of transmission to the unborn baby. The treatment of choice is the drug tenofovir, and it's a single tablet taking every day. And as we've heard today, breastfeeding is not associated with a high chance of hepatitis B infection in infants born to mothers with chronic hepatitis B. So Tahay, can you kind of help us understand the reason why some Korean women who are prescribed a medication don't take them because they don't feel sick?
Yes, again, back in when we were living in refugee camp in Korean state, we never had like the Western and medication. We normally only use medication where we need it, like when we have the symptoms for any like medical problems. So in here, they don't really understand that, even though we never had tests before, and when we came to Australia, we all have to get tests, and that's where we found out all these, disease that we have, like a hepatitis. And even though we found that out, a lot of people just think that the tests are wrong, or they would just be like, oh, a lot of people have it. It could be just a disease that will affect them. It's just something that they have. Or, and if they don't have symptoms, they don't feel like they need to have the medication taken.
Thank you. Okay, so we're just going to move on to our case study presentation. So what we're going to have is just an explanation of a combination of some real case studies that we've worked with in the last couple of years, and just some points of importance and of interest. So we can see here that we've got Gigi, who's a 27-year-old female. This is her second pregnancy. She's 27 weeks. Her hepatitis serology is there, as you can see. And the important one is to remember her hepatitis B-E antigen. And for those who are a little bit unsure about what that means, an E antigen that is positive means that we've got active replicating virus happening quite substantially, and you can see that her viral load was very high. And so the recommendation, of course, is to commence on treatment. So we've heard today that antenatal testing is really the only time universal testing for hepatitis B occurs, but as we do know from those previous data, it doesn't happen all the time, and that some women will only be learning about the hepatitis B diagnosis at the same time of their pregnancy. Gigi did have antiviral treatment in her first pregnancy, which was 12 years ago. Tahay, for women living in the camps, would they mostly have their babies in a medical centre or at hospital or at home?
So in the clinic, we only have one floor in one room, one big room. So like there's no privacy for anyone. They do have like a slightly like they cover with the curtain for the baby to deliver, but you can hear and everything that were in that room. And so a lot of people chose not to go to the clinic because it's like one, they don't have privacy because there's a lot of people in the hospital, so they prefer to have the baby at home, and they ask their parents or like neighbours, elderly neighbours, to help them to deliver their baby.
Thank you. And then also, I suppose, from a midwife's perspective, it's really important for us to reiterate that routine antenatal testing should include all the three tests for hepatitis B, hepatitis C antibody, HIV antibody, and of course syphilis, chlamydia and gonorrhea. And with our increasing STI rates, often a first diagnosis of some of those infections occur in pregnancy as well. So just moving on, we're going to talk a little bit about health literacy, and that's the core fundamental aspect of good communication, is to be able to communicate well. And many years ago, I was privileged to have to be involved in a forum with the Korean population when they first came to Bendigo about 10 years ago, and I was very in awe of the attempt for people whose language wasn't English to try very, very hard to understand us speaking to them in English. And it hit me like a hammer to the head that it was not their problem, it was my problem that I didn't understand them, and sent us on a journey to try and improve that. So we know that in Karen, the Saw dialect speaking is a patient. So our case study is a Karen Saw dialect speaking patient with limited English and not confident in English. Gigi did have face-to-face interpreters used as her preference, but sometimes we needed phone interpreters, and that talk-back method was utilised. So despite using correct language, dialect and trained interpreter, there still was some confusion and misunderstanding of health information and plans for Gigi. Tahe, what language do most Karen people in Bendigo speak?
Waginyo pula Bendigo ni adaki deweda waginyo glot show waginyo nila.
Did everybody get that? Would you like to translate?
So I was saying, in most of the Karen people settled in Bendigo are speaking short Karen.
Thanks. So health clinicians and everybody really here is encouraged to be aware of the health literacy of our clients when discussing their results. It is very possible to misinterpret the use of words positive and negative that may be equal to good and bad. And as we know, there may not even be a word or an understanding of hepatitis. Using words like virus can lead to confusion and misunderstanding that they might actually be diagnosed with HIV. We've heard today about the term healthy carrier or carrier that should not be used, and I do agree with our previous presenter that it is very disconcerting when we see referrals coming into our service with that term being used. Tahe, what kind of privacy and confidentiality issues could be experienced by people in the Karen community when face-to-face interpreters are local members of the community?
Yes. So back when in the refugee camp in Karen State, there's no such things in confidentiality and privacy. So it's the same as here because the Karen community are very based. Like we're very community based, so most people know each other, and it's still really hard to there's a lot of barriers, especially for older people. They have trust issue because that still applies sometimes in here, and everyone know each other, so it could be a really unsafe place for a patient to seek medical professional health and then have an Karen interpreter there. Telephone interpreter could be a really good option for confidentiality and privacy, but there's also other barriers in telephone interpreter as well, because I have experience where there's like an interpreter on the phone and then they don't know the context of the appointment, so they mistranslated the whole thing completely. So that's create really issue as well. Yeah.
Thanks. Okay. So moving on. So with our case study, Gigi had different medication used this pregnancy than last pregnancy, and the side effects of that medication, of those medications, were similar. The dosing was the same, but there was significant barriers to adherence. When we do scripts for hepatitis B treatment in pregnancy, the scripts are actually capped at 8 weeks so that we have a bit of a capacity to monitor when the scripts are collected. And sometimes with our client there is also iron deficiency, which is quite common in Karen women who are pregnant, and we were encouraging Gigi to have the medication as a piggyback with the iron supplements. In terms of our work with pregnant women who are on treatment, they're referred into the infectious diseases, and it is actually the infectious diseases nurse consultants who support these women throughout their pregnancy, usually a face-to-face consult, which we had, and also liaising with the pharmacy, the midwives that Gigi saw at the antenatal clinic, and also the GP if needed. One of the questions that I have in regards to medications, Tahe, is that could you explain why some reasons why Karen refugees would not want to tell their healthcare provider that they actually have not followed their plan of care and taken their tablets?
Yes, as part of Karen, is part of who we are is like we don't want to disappoint anyone, so we say yes to everyone. Even though we don't understand something, we will still say yeah, and even though we find it hard to do something, we don't want to express it because we don't want to disappoint anyone, even though it is disappointing someone.
Thanks. Okay. And can you tell us why Karen people may be reluctant to report side effects of medication and why they would suddenly stop it? And what are some common ways that we perhaps understand what they might say might mean that they've got a side effect?
Sometimes, like when they hear about the medications and like through the friends or family, they hear a story with like the side effect happen when they take certain medications, and instead of looking at the treatments, like the things that would benefit them, they focusing on the side effects rather than that. So, and they don't necessarily understand it completely, and they also don't want to like really find it out. They trust their friends, they trust their family better than other people. So.
Thank you. Okay. So, of course, part of the care of a person living with chronic hepatitis B in pregnancy is to have planned follow-up 3 months postpartum. So during the consultation with the infectious diseases nurse consultant, there is discussion around the hepatitis B vaccine and immunoglobulin to be given within the first 24 hours. Bendigo Health has a very detailed care of a woman with chronic hepatitis B in pregnancy policy that is adhered to in the maternity unit. Our babies are washed according to policy. Our baby in this case study had age-appropriate vaccinations as per the Victorian immunisation program. Our baby in this case study, the testing for the mother was very high in pregnancy, and what had happened is that she had reported that she had failed to communicate to us that she hadn't completed her medication and that she'd only had a couple of days of treatment, and she didn't want to tell us that. So our policy is around the commencement of breastfeeding as long as the mother's breasts and nipples have been washed with soap and water post-birth. The baby is bathed as soon as possible. And of course our policy includes the passive immunisation of immunoglobulin and the vaccination and postnatal care. At Bendigo Health, it's a very busy maternity unit. Most women who have vaginal birth stay between 12 and 48 hours. So it is very important that we are able to communicate with our refugee women who have had babies that there is ongoing care for them post-birth. Tahe, in the Karen community, who would a new mother generally go to for advice around breastfeeding or sleeping worries about their baby?
Usually the Karen women who have new baby, they would go to the parents or the parents-in-law or any elderly in the community who are more likely to have experience, because they trust them, because that was the only option we had back at home, back in the refugee camp. So they would go to them for advice.
Thank you. What's really critical in terms of postnatal care is the communication between the mother and her baby and the community services. So there is domiciliary midwifery services that generally contact the mothers when they go home, and that may be during COVID time, that was often telehealth. Now there's some face-to-face visits. And then there's a referral to the maternal and child health nurse services. One of the critical things in the communication of ongoing care for women with chronic hepatitis B in their postnatal period is ensuring that the GP is aware that all the guidelines have been adhered to, and that there's an expectation that that baby will be tested between 9 and 12 months. One of the gaps that we've found at Bendigo Health is that that always doesn't happen, and so we've tried to instigate a policy where we actually have a referral to the paediatric service, so that family are red flagged in regards to that. And one of the working in progresses we have at Bendigo Health is to ensure that every mother that has had a baby and has chronic hepatitis B has an ongoing referral to the infectious diseases service, so that we can continue to monitor her. Women on treatment, as I said, are on treatment for 3 months post-birth, and then they come back and we do another viral load. And we're concerned about a flare that may occur when medication has ceased. And then not every woman as we previously heard today, would require treatment in future pregnancies. However, it is incredibly important that we maintain them in our service. The following up testing of our baby was attended, and we'll tell you the whole results. We had a beautiful baby boy born at 39 weeks. All the protocols were adhered to. They stayed 2 days in hospital. All the vaccines were adhered to. The baby was tested at 11 months and was reported to be negative for chronic hepatitis B. Gigi came back to our clinic and has subsequently been engaged in our service. And one particularly piece of interest in this family was that her partner was tested and found to be not immune, did not have chronic hepatitis B, and actually was vulnerable to being infected, and was given an accelerated course of hepatitis B vaccine. I think that's the end of our presentation.